Estrogen is breast
Breast
protective.
protective.
And if you take estrogen, even Premarin, you're going to have less risk of breast cancer. And if you do go on to develop breast cancer, like Fiona just said, and this is very
Mhm.
clear too, you will have better outcomes and less, like 50% less chance of recurrence.
Yeah.
50%
And
chance, less chance of recurrence. That's big.
That's huge. Yeah, that's
that's huge.
Dr. Avram Blooming talks about that.
So
He's
good.
a breast
Well,
cancer oncologist.
and 90+% of women that end up experiencing breast cancer survive. That little bit of information gets left out of the conversation. I think we've all interviewed Dr. Jen Simmons on this on our shows. She is a
Yeah.
great resource for things around breast health, etc.
All right. It's a real pleasure to have today my Meno besties, who we've just renamed my Meno Beauty besties, Karen Martel and Dr. Fiona Lovely. I'm so excited you're here with me today. We are recording I guess we're doing this every 3, 4 months. We're just kind
Yeah.
of getting together and ranting or talking about the things that we
Mhm.
love to talk about, that we know that you girls love listening to as well. So Karen Martel, just in case you don't know, she is a certified hormone specialist, and she's the host of the Hormone Solution podcast. And if you haven't heard that yet, please go. I'll have links to that in the show notes. And Dr. Fiona Lovely, who's the host of It's Not Your Mother's Menopause podcast. I think you win the prize for like best podcast title ever.
Thank
Name it.
you.
And longest. She's like what had one of the first menopause podcasts, didn't you, Fiona?
Yes, nobody else was in the category when I uploaded it in
You're such
late 2015.
That's amazing.
amazing. Such a
I was the
pioneer.
OG.
The
The
OG.
The
OG,
OG.
yes.
Exactly. Exactly. And I heard that Dr. Mary Claire Haver is now just trying to start a podcast, or going to, or something like that. Everybody's just coming on the bandwagon now. And here you've been doing this forever, right?
Well, you guys
Yeah.
too, right? I mean, we were early voices. It's so important. I was recording another episode with a guest talking about adenomyosis, by the way. If you guys want to have a guest on to talk about that, an expert, very interesting. And I said to her, I said, we need advocacy and we need education, because we can't expect that our healthcare practitioners were trained in how to take care of women's needs and women's pain. And despite the fact that we are 51% of the population, that we will spend 40% of our lives in menopause, it's a blind spot. So go in educated to see your doctor, because that way you will ask better questions. It's a much more efficient process. It might still be frustrating as hell, but at least you'll feel
Mhm.
like you did the advocacy part.
And have you guys not noticed like the increase of negative talk about the menopause awareness that's happening? Like how many people are going, this is just
Crazy.
becoming a money grab, and it's pharmaceutical companies are making billions of dollars off of this and off of women. And I'm like,
No.
like,
Mm-mm.
yeah, no. Hello,
No.
we need this to be happening. It doesn't matter if some of the information, I mean, it does matter, but yeah, some of the information might not be great. But all in all, we need it to be talked about. And
Yep.
when you look outside of this, the social media and outside of the functional kind of wellness space, it is still not being talked about
Hmm.
enough. And when we look at the numbers, I think it went from 4% of women were on HRT since the Women's Health Initiative, and we're only at 7% in the
Yeah,
last
not
two
enough.
years.
Yeah.
Yeah.
So, hello, this isn't some trendy, oh, we got to stop talking about this because
Hmm.
it's getting over talked about. No, we need to continue to talk about it and talk about it more and shout it from the rooftops.
Yeah, I agree. It's probably because some people, your social media feeds get populated. It seems as though you have this interest in menopause, so then it feeds you more and more. So it appears that
Right.
everybody's talking about
Everybody's talking
menopause,
about it.
or
Yeah.
everybody's on hormones, or everybody. And it's actually, like you said, it's 4%, 6%.
Hmm.
In the UK, it's about 10%. It's different in different parts of the world, but it's still very low, very low. So I think it's just, yeah, if you don't like hearing about it, well, then you just go and set your
You can
algorithm
actually, yes,
differently in
exactly.
social media.
Yes.
You
And
long
don't worry
press.
about the money and supporting big pharma. I'm so tired of that, hearing about that too. It's like, you guys, like big pharma, yeah, they're trillionaires. They're making a lot of money from sickness. But at the same time, we wouldn't have the medicines that we do today that are life-saving if it wasn't
Mhm,
for them.
mhm,
And
mhm,
yes, there's always going to be a buck to be made from
mhm,
wellness and
mhm.
health and medicine. So,
In
like,
any
let it go.
industry, it's always,
Yes,
there's
everybody has
always
the right to
somebody
make money. That's the way I see
trying
it.
to profit.
Mhm.
Exactly. And in the end, depends on, it's not that bad to be making money from some things, as long as you're not riding off the back of other people or making them worse or not helping them. If you're helping people, then I'm sorry, I'll give you my money.
Yeah,
Make me feel better.
100%. Yes.
I know.
I didn't do all this work to do it for free. Like there was
Yeah,
a lot
yeah,
of
yeah.
education that I had to take. You guys too. It costs money to go to school to become an expert at something, right?
Yes.
But I think some people use this scenario where they like to badmouth other people or put people down because then it's more clickbait. Then it sounds like they're telling the truth because everyone else is lying. So then you
Right.
better follow me. That's the way social
Ick.
media works.
Icky, 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 icky. And I like to think that the listeners of our shows are discerning enough and smart enough to see that and go, "Pfft, next,
Yeah.
right?
Yeah,
Long
yeah.
press and then tap the not interested button. Moving on.
Exactly.
They are smart. They are very smart. And I think there's sometimes people ask me about my audience, and I say, well, I always I like to protect them in a way because I
Mhm.
try to explain there's a lot of predators out there and they're trying to sell something. And so if I'm going to talk about a product, I have to be do my due diligence and make sure it's good. And I don't want to protect my audience. But at the same time,
Same.
my audience is smart too. They can
Mhm.
smell that something fishy a mile away. And I tend to underestimate that sometimes. And I don't need to protect them. They're fine
Mhm.
without me.
Mhm.
Like they know it.
And don't you guys just love your audience? Like,
Oh,
99% of the time, the stuff I get from women, I just got one the other day, and this woman was like, oh, I emailed her and she's like, oh my God, is this the Karen?
that's so cute, isn't
I
it?
love
I
that.
was like,
Oh,
oh
you got
yes, there we
hearts.
go. Hearts. And I was like, yes, it is the Karen. She's like, oh my God, thank you so much for what you do. And you've helped me. And then I'm just like almost in tears because it's so wonderful. And I feel like most of my audience, and I can't see them all obviously, but I feel like they're good people. I think that for the most part, we get goodness.
Oh my
Yes,
goodness.
I agree. This is also why we are drawn together as the Menno Beauty Besties because we have a similar take on things and we've got people that will enjoy each other's podcasts. And it's the same thing. We work to protect, we work to educate and teach advocacy. And I don't know, I'm with you. I just love the hell out of my people. I love it when they
Yeah.
send me emails. You guys, if you're listening, send me an email through the website. I love to hear from you. Messages on Facebook or Insta or TikTok, wherever. Actually, the messages on TikTok are a bit dodgy. They're not coming. They're not coming from the listeners so much, if you know what I'm saying. And if you think I really believe you're Jason Momoa, I've got an elevator pass to sell you.
Oh my God, you girls are so much
Oh,
fun. I want to
yeah.
tackle some questions or some topics I think that need to be addressed because there's a billion and one of them. And actually one of them was about the question of am I in perimenopause or is it just stress? But it's so funny that I had this on my list of that I'd like to cover because literally just before we hit record, I got this message on Instagram and it's so typical. And I'm sure you girls have also got messages like this. She says, hi, if you might have the time to answer, is it normal to skip a period when perimenopause starts? I'm 46 and 4 months back, and I had a delayed period, and the same thing is happening now. It's been 2 weeks since a normal cycle, and period hasn't started. Is this normal in perimenopause?
Oh my God, that's so funny. Of course this comes up because the last two like big questions that were posted in my community in the last 2 days were two women going, My period is coming every 3 weeks right now. Like, what's wrong? How do I fix this? I've done this, I've done this. And I'm like, whoa down, ladies. This is normal. I just got a period again, and I just had one 2 weeks ago. And prior to that, I missed a period. And then I was having it every 3 weeks for 6 months. And then I was like, and this has been going on for years. It's
Yes.
so normal.
Yeah.
It's sometimes these simple questions that we tend to even forget because it's so basic. But I think most of the women out there have no idea. And I'm not saying our listeners are obviously up to speed, right? But I do, some of my best Instagram reels are just about the signs and symptoms of menopause. And you just list like 10 of them, not hot flashes and night sweats, because that's the thing that people are always expecting. But some of the very simple ones too that people may not associate, like joint pain, disrupted sleep, or anxiety, or mood, or these stressful situations. And a lot of women who are in their 40s are just not expecting it. Maybe they haven't heard of the word perimenopause yet, or it seems to be something quite new to them. But rest assured, wonky periods is what I call them, kind of on and off. You know something's off, and that's usually in the very beginning. That's when I'd say, well, that's probably early perimenopause, because we have the early and the mid and then the late perimenopause, and they all seem to be like different stages within perimenopause. And I have a feeling there should be the same terminology for postmenopause, because we have early postmenopause, which is several years after your period stops, and then it's like everything else is the same. But I don't know. I think there should be different classifications of what's happening in your 60s or 70s or 80s, especially if you are still dealing with hot flashes and night sweats.
100%. And
Sorry, Fiona, go ahead.
this will be something that I think will evolve as those of us that are advocating and educating, as we get into those menopausal years, we'll start to break it down, just like happened with perimenopause. I mean, I remember the term perimenopause came online probably 12 years ago, something like that. I remember hearing somebody say that, what the hell is that? I'd never heard of that. I'd been talking about women's health for almost 10 years at that point. But something I want to bring up to the question from your listeners, Zora, is that most women are not even aware of when perimenopause starts because the symptoms are so subtle. And so by the time she is having period changes, she's midway through. She's midway through the perimenopausal phases, right? So the healthcare providers for her have just failed to say, hey, listen, this is actually what's happening. Totally normal. It's all good. It's not early perimenopause. If you're already having, what happens is the cycles get shorter to start, and then you'll start to skip them, or they'll get longer, etc. And Karen's right. Like, I had 2 periods in May, haven't had one since. My chiropractor asked me this week, he was filling out a radiology requisition for me. He's like, any chance you could be pregnant? I'm like, no. Oh, shit.
I hope not.
Then I was
Wait a
like,
minute.
furiously looking through my phone. I was like, oh my God, when was the last time? Oh my God.
Yeah, because how old are you now, Fiona? Can I ask?
52.
52. Okay.
Yes.
Yeah, still, it could be possible, right?
Oh God, I hope not. Sweet baby Jesus. No. No.
Well, Zora, we talked about this on the last podcast we did together, that you and your husband are still using protection.
Yeah. And I'm 50.
And I was just like, what? Pull the goalie already. Is it happen?
He doesn't believe me, but I see you're bleeding. I'm like, it's called a fake bleed. I'm taking hormones. And he's like, no. What, a woman in her 60s never had a baby? And I said, well, I don't think naturally. It's crazy. I can't convince him. That's why I want to get this little device called the Mira. You heard of the Mira? It's this little, you can test your urine every single day. And I have tested the ovulation for a couple of months, because those things are freaking expensive too. And
Come up?
What?
Anything come up for ovulation?
No, not ovulating as expected.
What's your FSH last time you had it tested? Do you remember?
I don't remember. I was looking for it. Started to look for it the other day because I hadn't tested it in a long time. And then I was like, what's my episode? And I got distracted, never saw it. So I have to test it again because I want to see where it's at. And I got to somehow convince him, like, we don't need condoms anymore. Honestly, honestly. I've been with him for
I
30
don't even
years.
believe that. Yeah, yeah.
I
What do you
know.
think? How do you
Just
just go get a
really don't want
vasectomy?
another child, eh? It's like, no, we're not
Clearly
taking any
not.
chances.
Yeah, yeah. He's just worst
Oh,
case scenario, like everything.
yeah. I was gonna say I was what exactly what you just said, Fiona, which is had somebody asked me that when I was even in my early 40s or
Yeah.
late 30s,
Mhm.
what do you think perimenopause is? I would have said, oh, it's a few years, like not
Mhm.
even
Mhm.
before menopause
Mhm.
hits. And I
Mhm.
think that women don't realize that perimenopause is typically starting in your late 30s, early 40s. That's the most common age. However, that's getting earlier and earlier. So we're seeing it now in 35-year-old women that are starting to lose their hormones and their ovarian function. And so I think that women need to realize this is a 10 to 12-year time period on average where you start to lose your hormones. And going back to that original question, is this stress or menopause or perimenopause? It could certainly be a bit of both because stress can actually make you go into perimenopause or start losing that ovarian function even sooner. If you're highly stressed and your cortisol is running all the time, it can start to affect the fertility and head into menopause a little bit sooner. So it could be a little bit of both.
Yeah, actually, there's if you don't, maybe I'm sure many women have heard of this, that if you're pregnant at 35, it's called geriatric pregnancy.
Bananas. Who comes
That's
up with this stuff? Bananas.
you're
Carry on.
35 and you're told you're a geriatric pregnancy. You're like, what? But that's because we're losing our hormones. It's getting harder
Yes.
to have a baby when you're in your mid to late 30s and early 40s. Some people are extremely fertile. You're probably going, that's not me. But yeah, geriatric pregnancy, that's so when we look at things from the lens of hormones and just not talk about menopause or perimenopause, but this is just another phase of life where our hormones are acting very strangely. We had
Mhm.
pregnancy, we had our teenage years, adolescence, and this is reverse puberty, is what Dr. Carrie Jones always calls menopause. And it kind of is. It's just another phase where our hormones going to go crazy. You can label it whatever you want to label it, but unfortunately, I think we need to rebrand the word menopause because there's a stigma with it. It means you're old and people are ageist and they don't like that word. And so they'll resist it. So many women I've interviewed on the street who just say, oh, I didn't do menopause, even though they're 65. I'm like, what do you mean you
Yeah,
didn't?
you did.
Like, you didn't have
You
menopause? Like,
I didn't go there.
did. Don't you wish you could just be
I
like, "Meh,
wish.
okay, I'm gonna not recommend that. My Yelp recommendation. Do not recommend.
yeah.
Wait,
Yeah.
aren't we calling it cougar puberty? Isn't that what we're
Oh,
calling menopause?
Oh, I haven't heard that. Oh,
Cougar
jeez.
puberty.
Cougar puberty.
oh my God.
But it is very similar. I mean, at this time, you're not going to ovulate every month, so that's going to mess things up because it means you're not going to be producing progesterone. And then, like you said, Zura, the cycles get shorter, and then once you hit mid 40s, now progesterone just plateaus. And then estrogen starts to go up and then it goes down. And so you'll have heavy periods and every couple weeks periods. And then suddenly it'll go really low and you miss a period for a couple months. So it's a roller coaster.
It's funny, but I haven't had that myself, to be honest. I haven't had the roller coaster periods
I
because
have.
probably I started hormones before that even happened. I started at 50 but my periods were totally regular. I'm one of these lucky ones who just was uneventful period my whole life. It's just been
Wow.
several days, light, normal, like nothing, not a big deal. So I just
Not
transitioned
fair
into
as a
that and then
woman.
I took the hormones. So I've only had a couple, like when I had my surgeries, my periods stopped, which is stress, like you said.
Stress, yeah.
Stress can do a number on your ovaries. And then it came back. But again, I'm on hormones. So and when I started hormones, I remember telling the first doctor I ever saw who claimed to be a specialist in women's health, told me, oh, I don't need hormones. Why would you want that? I watch you on Instagram. You have a great lifestyle and diet. And I'm like, well, I just want to have a smooth transition. I hear you're going to fall off a cliff. I didn't know anything. And in the end, that was my objective. I said, look, I really do want a smooth transition. I don't know what's going to happen. So let's just start early. And I understood the timing theory. And I thought, okay, let's go for it because I have to make a decision if I want to just do this or not. And I did. And I'm glad I did.
You
So I hate
advocated,
to be
which
one of
is
these
good. Yeah.
people, but I haven't had that crazy, crazy periods, heavy periods, light periods. I've had it go longer, a little bit longer than normal. I've skipped some periods before, but nothing really dramatic. So I can't complain.
I've had all
Goodness.
the drama.
And
But we
Karen, I
won't
think
go there.
you're fairly open about your health
I
journey.
am.
There's some AI stuff for you, right? Some autoimmune stuff.
No, just
Thyroid?
autoimmune in nature, thyroid.
Yeah.
Yeah. But I
Okay.
have a history of tons of hormonal garbage, right? Like
Yeah.
endometriosis, ovarian cysts, blocked tubes, scarring down there. Yeah.
Yeah.
So I've always had stuff like that. Horrible pregnancies. And you're like,
Well, to talk about the stress piece for just a quick second, I never skipped periods with stress. I bled like I was shot when I was stressed.
Oh, really?
the
Which
opposite.
didn't make
Different.
anything easier. Like,
No.
not at all. I think we all respond to things a little bit differently, but certainly stress can accelerate the symptoms of perimenopause. And Karen, you mentioned perimenopause is that 10 to 12-year duration. And we're talking about the brain. It's a 20-year, it can be a 20-year renovation of the brain. Okay, so
Wow.
we're
Like
talking
starting how early?
30, 35.
Wow.
Well, that makes
Yeah.
Okay.
sense. Perfectly in line with
Yeah.
losing our
Well,
progesterone in our mid 30s.
Yeah.
absolutely. You start to think about what I know for me, this is true for my patients as well, generally speaking, is that the first signs of perimenopause now looking back were I can't elevate my mood like I used to. I have
Mhm.
anxiety. I can't sleep. Guess what? Those are all brain based,
Hmm.
right? And so when we look at, of course, a friend to all of us, Andrea Donsky, and her white paper on the symptoms of
Yeah.
perimenopause, of the top 10, 9 out of 10 are brain-based.
Wow. I
Wow.
know. That was so interesting, wasn't it? I remember her telling me that, and I'm like, what? Really?
Yeah,
And
with
they
that
found
information.
something, they documented 100 different symptoms, was it? Of
103.
perimenopause? 103.
103.
Yeah.
Yeah,
Yeah.
Yeah, she
Which
love
has
just
them
it.
goes
all
to
on her.
show. Yeah.
Yeah, she has them all on her website, which is really good. She documents them all and explains in detail how it's connected to menopause or the loss of hormones. And this is a great resource, actually. I really
We
like it.
are morphus.com.
Yes, there's a plug
Yes.
for you, Andrea.
Yeah. Exactly. Well, and I reference her research when I'm teaching my menopause doulas because it's so important to know exactly what these symptoms are because we can address them with or without hormones. We can teach our clients, our patients to go ahead and advocate for themselves with their doctors, but what are the things we can do lifestyle wise? And I think that's really important. Something
Mhm.
you said, Karen, about doctors just saying, "Oh, you don't need hormones, that's whatever." I think I told you guys this story the last time we had this conversation. So if it's familiar, I apologize, but it's so shocking. It's so good to tell again. I had a patient tell me now she's in her 60s. So this would have been 20, so maybe 15 years ago. So Women's Health Initiative is still ruling. It may have even been before that, 20 years ago. She asked her doctor for Premarin, and her doctor said to her, and I quote, "Why would you want that? That's the bitch pill."
Oh my God.
Yeah.
Kidding me.
She sat in that chair and told me the story.
The
And I
doctor,
was like, yeah, that's what the
the
doctor said.
bitch
That's the
pill.
bitch pill. Yeah, exactly. And I was like, whoa. Can you imagine a female doctor responding to a guy who came in and said, my penis doesn't get hard? Something similar? That's just what happens when you get older. It's the
Yeah.
limp dick syndrome. Moving on,
Yeah.
right?
Your
It would never
Viagra's
happen.
the asshole pill. How about that?
That's the whole pill. Oh my gosh. We have so much work to do. It's just,
Yes.
we're still
Yeah.
so far behind. I hope for the next generation, it'll be a lot easier and doctors will be much more informed. And until then, that's why we have to advocate for ourselves and read as much as we can and listen to our podcasts and read the research if you're able to do that or get really good with AI to try to filter things out. But bone up on menopause and you're going to be a better person for it, because you'll come into your doctor armed with information, and don't let your doctor gaslight you. Because sometimes I've heard women in my community say, well, I've come in and I thought I was really prepared, but the doctor just disses their patients completely. And I said, that's time to fire your doctor and find somebody new who will listen to you. So sad. It still happens.
It happens all the time.
Yeah.
All the time. I had a new patient yesterday, 53, still cycling, not sleeping, seen her doctor several times and has said to him, can you please just check my hormones? And he says, no, I'm not going to check your hormones. They change all the time. There's no reason for me to check your hormones. Sure enough, I go into Alberta Health Services Net Care to see what's happening, and the only hormone he's looked at is TSH. And again, guys, there are not bad doctors. I mean, there are bad doctors, but this is not something we don't step into this going, well, I'm going to be an asshole. No, you're taught in a system that is male-based and reproductive-based. And so if you're not one of those two things, then there starts to get less and less information. And so that's all that is. And this is why it's so important, again, as we started off this conversation, to just be an advocate for yourself.
Let's talk about lab testing, since you brought that up, because that's another thing that's really confusing in our world. I think women want to be tested, and then very often their doctor says the same thing. There's no point. And there's no point in testing your hormones, let's say your sex hormones. So they're assuming that you want to just do estrogen, progesterone, testosterone. But I personally think that there's a whole other slew of lab tests that you should be doing in around this phase of life. And I think you should be testing, I don't know, your whole life. This is the biohacker in me, is like, let's test, measure, and assess. See where we are when everything's great. I mean, if you're listening to this and everything's fine, your periods are fine, and you don't feel menopause yet, still get tested, like, while everything feels good. And you know what your baseline is, right?
Yeah. We have to start bringing the two worlds together of listening to a woman and her symptoms, as well as looking at the labs, and not going 100% on either one. Like, we need to pull them together, because symptoms could mean so many different things. Because if a woman's tired, emotional, not sleeping, has anxiety, well, guess what? That might not have to do with your hormones. That could be a multiple different thing. Could just be this day and age, for heaven's sakes. This could be being a mother. There's so many things that it could be. And so, yeah, you want to match it to what are the labs saying? And then you also want to test your hormones, especially once you start HRT, so that you know that you're getting to good levels, not exceeding, what you should be taking, because a lot of women do, especially with testosterone, right? That's given in really high doses right now to women, and they're androgenizing women. And you see these women and they're getting whiskers on their face, and they're losing their head hair and having greasy skin. And then you get women that are given this tiny little baby dose of estrogen, which gets rid of the hot flashes, but that's doing nothing for their brain and their bones. And so you want to see on paper, okay, where are you at? Because we need your estradiol to be at in this range that is going to is more likely to give you that protection that you're looking for, the brain, bone, and heart protection.
This reminds me of a friend of mine who just started her hormones. She was so afraid of them. Oh my gosh, it was like so hard to give her the information, but she finally started. And then she had a screening. I don't know if it was a mammogram or something. I think it was a mammogram. And they were like, oh, we found something. We're not really sure. So then her doctor said, stop the hormones. So she stopped the hormones. And I said, well, okay, actually, it'll give you a chance to see if, what you were taking is working or not working. And she's like, I don't feel anything either way. I'm like, then nothing was working. You probably weren't even taking enough hormones if you didn't feel better. And then imagine if you did take the hormones and you did feel better, and then when you get off of them, then it gives you a chance. You should not feel as good. And then these are working or not working based on your symptoms. But she never got tested. They didn't seem to work. She didn't have close communication with her doctor. If you're not feeling better in the first several weeks, I would say at least send a message, an email to your doctor. I don't know, it's not kicking in, and maybe it'll take a few more weeks, but at least you need to stay close to the doctor and don't wait 3 months until the next appointment and feeling like garbage. Well, you probably need to change the dosage if you're not feeling anything.
Yeah, 100%. And what I tell the ladies that I talk to hormones about is it's not going to be one dose that you're taking for the rest of your life. There's levers here. We have to push them, pull them, just depending on what phase you're at, what symptoms you're having, what your labs are showing. So you have to be communicating with your practitioner for sure.
How
Mhm.
often do
Yeah.
you, I know, Karen, you have your community, so you can meet with them pretty much every week if they want to come and talk to you, which is great. But Fiona, when you have a patient, and who's just starting on HRT, is there a protocol that you have for them and say, this is how you're going to communicate with me, or I'm going to see you every 3 weeks or 4 weeks? What's the timeline like?
Yeah, so the nurse practitioner who does the prescribing is the one that's sort of taking care of the labs and reading the labs and doing the prescription. So my job is as the coach to step in and say, okay, we need to tweak a little here and communicate with her. Or they always have access to me for via email. And of course, we can always book a phone call if necessary. Most women do quite well on their own, but the biggest thing is just to encourage them to reach out if something doesn't feel right, because we're not great at that. We're not complainers. We're told to shut up and put up, really, ultimately, to be very plain about it. And so to encourage women to be collaborative with their prescriber or their healthcare provider is really important. For me, I follow up usually every 2 months, but then as things start to stable, we kind of go 6 months kind of thing. And then I leave it up to them. If they want to reach out to me whenever they need a coaching session, we can do that anytime. So it's really very much driven by the patient up front. We do more frequent care, but as things stabilize for them and they feel more like themselves, then we don't need to follow up nearly as much.
I love
With
that.
our legal, or no, I was going to say our legal team, our medical team, right now in the United States, which is primarily where what we service as United States, right now, testosterone, if you're on testosterone therapy via telemedicine, they usually require every 3 months for the first year
To
with
test
labs
or to
to
meet.
test for testosterone because testosterone is considered like a narcotic class 4. It's like, whoa, it's so stupid.
I know.
But anyways, so for that, but with estrogen, progesterone, it's not as often. And so if it's just that, then what we do is have the initial, a 3 month, and then every 6 months after that. And that works for the majority of women. We have the odd woman that will be like, I need to see you more. I need to come in more. I need another visit, which is okay, no problem. If you need us
Yep.
more, if you get the odd woman that is a tough case where
Hmm.
she doesn't feel good on the hormones, she's having an adverse reaction to them. And so you have to really go, okay, let's change the dose, let's change the delivery form, let's change the type. There's lots of different things that we can do. And I don't think there's ever been a person that we haven't been able to find a good match for. But the odd woman does need a lot of tweaking in order
Hmm.
to get that optimized on her hormones.
Hmm.
Majority, though, or if they feel good, we can very easily optimize. And it's just a matter of, okay, at the 3 month, it takes about 3 months for the hormones all to interact with each other and you kind of settle. And then you can go, okay, let's see where your levels are. Do we need to increase here? Are all of the symptoms gone? Because like Fiona just said, women will be like, I just feel so much better. Like my libido's back and blah, 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 blah. I mean, I still have some dryness and I still getting hot flash. I'm still getting this. But you know what? All in all, I'm just so much better. And no, do not settle for
Hmm.
anything but all of
Hmm.
them gone
Hmm.
because
Let's
that's
keep
possible.
tweaking. Yeah,
Yeah.
keep tweaking and keep optimizing. I find, Karen, that usually the women that have that need more care, let's put it that way, that
Yeah.
need more care are the ones with thyroids that are not easily
Yeah.
regulated. And that's the one you want to keep an eye on for sure.
Yeah, yeah. I've been getting really into the effects of early childhood trauma on
Yes.
hormone receptors. and
Tell
how
us
they can
about that.
well, I don't know
Yeah.
enough yet to talk about it. I'm I've just done a deep dive into progesterone sensitivity.
Yeah.
And in that deep dive, I did come up with some studies that showed that unresolved trauma from childhood can affect hormone receptors, that in later in life, in perimenopause and menopause, it can really start to present itself as like with issues, emotional issues, and sensitivity then to hormone replacement therapy, where they don't feel good on it. And there's a woman that's coming on my podcast in October. She's writing a book about it. And she's somebody that has childhood trauma and then went to do HRT, had this horrible experience, and was like, why is this happening? And so she's been really trying to dig into the research, and there's not enough, obviously, but she's the most well-versed, I think, on it that I've seen as far as that goes. So I'm really interested to read her book and just to hear what she has to say and learn from her.
Karen, can you name drop her?
I will look it up. I can't remember. She's got a interesting last name.
And while you're looking, let me chat about
Yes.
this for a second.
Okay.
Okay, this is news to me. I have not heard this before. You guys, I think, are aware that my fellowship training is in brain health, functional neurology. And so we're learning a lot about certainly ACEs, or adverse childhood experiences, and how they affect chronic health for sure. There's lots of documentation around that. But interesting, you said unresolved trauma in childhood affecting hormone receptors. So here's my take on it. Could be talking out my armpit, shall we say. So I wonder if the fluctuation of hormones, or maybe the ramping back up of hormones, is like a reminder to the limbic system of the time of the trauma, if it happened around puberty or the onset of hormones, is what I'm thinking. So I'd be really
Ooh,
interested
so
to read.
interesting.
Isn't it though? We're
Yes.
learning so much about how the brain's ability to seek safety, seek stability, creates lifelong patterns that affect us across the board. Yeah.
This reminds me, interestingly enough, yesterday I did a podcast interview with Dr. Nawaz Habib. He's known as the vagus nerve doctor because that's
Ooh.
his jam.
He's in Toronto, right?
Yeah, yes. Yes. And I'm supposed to connect him to you and Karen as well because it was a really great interview. But I'm wondering what Karen's saying in terms of that you have the hormone receptors here. But what he was explaining is that the vagus nerve, this is starting from the stem of the brain, right, and going down, it's the highway to all of our organs. And if you're thinking about the organs that are producing hormones, then I'm wondering if those ACEs, those adverse childhood experiences, and the trauma is somehow connected to the vagus nerve, which would make perfect sense, which is then turn affecting the organs and then the hormone. It's the hormone production,
And the
perhaps
ovaries.
Absolutely. The brain perceives through the body. And so the body and brain communicate via the vagus nerve, of which we have two of them. There's one on each side of our bodies. And so our entire existence is modulated by the vagus nerve. So it's a really important relationship to study. And I think the more I've done the work that I do, the more I recognize just how important management of safety is to overall health, physically and psychologically. So again, listen to these interviews and drink in all the information. He has a great book. I can't remember the name of it. Maybe you guys talked about it. But yes, I know exactly. His body of work is excellent.
He's a chiropractor
Oh,
too.
Yeah, yeah,
Yeah.
yeah.
So
He sure is. Yep.
you're doing a podcast exchange soon. So by the way,
Amazing.
yeah.
Yes, perfect. I was like,
okay. So
hook me up.
Yes.
her name is Paula Rastrick, Rastrick.
Okay.
Now she's a little, I don't know if I would say anti-hormones, but a little bit. Like she's really trying to advocate the other side. So I can appreciate that.
Yes.
Where she's just like, quit making this sound like it's a one size fits all. Because she's like, there's people like myself who
Can't.
do horrible on hormones.
Yeah.
And this needs to be addressed, and we need to start recognizing what's happening here and what it's doing to our brain chemistry when we take these hormones, when we've had trauma in our past. So for some people, if they have a sensitivity to hormone replacement therapy, this is something to look into. It's another tool for the toolbox where maybe this is why. And in my progesterone sensitivity episode, I go into like the physical possible reasons why you might have the GABA receptor sensitivity, neurosteroid sensitivity, but then also talk about that, hey, maybe this is emotional, maybe this is trauma based. And that's something to explore as well, especially if you come from a history of trauma.
And frankly, in our generation, who hasn't, right? Karen, I'm really excited to hear that episode with Paula. So thank you for
Me
bringing
too.
that up. It sounds like a great topic. To me, when I hear that as a nervous system expert, I go, then the remedy to sensitivity to HRT should be trauma therapy.
Yeah, I
It
agree.
should be. So I'd be really interested to hear what she has to say about that. And all of my patients that I see, it doesn't matter if they're chiropractic patients or if they're head injury patients or if they're hormone patients that come to see me, we do nervous system regulating activities because these are tools that we can all use. I heard one of my experts this morning as I was listening to a lecture of hers said, we must be in the daily practice of dumping the stress bucket. Dump the stress bucket. Whether you feel stressed or not, you've got the stuff in there to get rid of. And of course, Zora, to come back to the vagus nerve, we use the physical self movement to activate the healthy pathways of the vagus nerve in order to discharge that trauma. What a fascinating subject. Karen, thanks for bringing it up.
Have you heard of the stellate ganglion
Of
block?
course. Yes, yes, yes. Yeah, well, as
That
a,
I,
yeah.
yeah,
What's
I figured you
that?
probably would. I know. I'm going to get it done. I'm determined.
What is it?
Okay.
Okay, so I'm going to get this guy on my podcast too. So I just listened to this the other day. He was on Dr. Gabrielle Lyon's show, and he does it. Dr. John, oh, she doesn't even have his last name here. Oh, Dr. John Howe. I was looking at the Howe thinking it was like Howe something or other. Okay. So Dr. John Howe was an emergency physician turned mental health advocate, and then he started to do the stellate ganglion block. Maybe you could explain it best, Fiona. But this is for PTSD, anxiety, depression. Is it the vagus nerve that they're blocking?
No, but it's in the neck. Okay, so it's
Yes.
just ganglion just means a collection of nerves. Okay, I don't know a lot about this, but
It's with a procaine,
first of
like a
all,
cane.
the blocks don't last forever. And a cane just means it's like an anesthetic, right? I don't know anything about how he's using it. So is he like using it to modulate the experience of PTSD so that the brain switches off those mechanisms and that way by the time the nerve block runs out, then you don't have those patterns anymore? Is that how he's using it?
No,
Okay.
no. It's very interesting because I guess one side is, I can't remember if it's right or left, has more to do with childhood trauma than the other side.
And that'll be where it feeds into the brain.
Yeah.
Yeah.
Okay.
So one side, yeah, yeah, that makes sense.
Little needle, he says, you doesn't hurt, takes 10 minutes. And so they use a numbing, like a procaine, something with a
Yep.
cane at the end of
That'll be
it.
the cane. Yep, yep.
They
Novocaine usually.
block
Yep,
the sympathetic nerve that's
yep.
going into the brain, and it puts a temporary block on it so that he said some people it's instantaneous on the table crying because he said it's like vacation in a needle. They get instant complete body relaxation and anti-anxiety sensations where they're like
Right.
for the first time and sometimes a lifetime. He said it can be very profound. Other people, it takes a little bit longer, but basically it can help bring down that anxiety, help with the PTSD.
Last, Karen?
He said most are 12 to 18 months.
Okay, interesting.
That's
It is really interesting. I'd love to know more about that.
And they do it in conjunction with ketamine for some people. And he said when they
okay.
do it with ketamine, which for everybody, this is a drug that is usually used as an anesthesia, but it's being used off label now in the United States to help with rewiring of the brain.
Yeah.
And so he said when they use the combination therapy, and then so they do ketamine with therapy in between the sessions. So they go see somebody that, which I think is very important to integrate what happened during the ketamine experience, which is done in office via IV. And then they mix it in with the stellate block. And he said it's pretty profound, but it can be used for pain, for chronic pain as
Yeah.
well.
Yep.
So I
Yeah.
looked it up
Well,
for migraines, and
yes.
it is
Are
being
you?
used for migraines.
What did you say his name was?
Dr. John Howe.
Okay, with an E?
No, like
Okay.
HOW.
I'll be looking that up. It's interesting because, so from a very basic point of view, the sympathetic nervous system's job is, by the way, do we feel like this is within the realm of menopause and we should keep talking about it?
Well, I
yes.
think it's so interesting.
Yes.
Yeah.
It's because also menopause, I mean, when people think about depression, mood swings, anxiety, it's not only hormones, right? It can be other things. So if it's happening in this age, more
And
or
women are
less, or in
far more
menopause.
prone to those things.
Of
Yes.
course. And what happens is we can mask our trauma until we don't have the props of the hormones anymore. And as the hormones decline,
Good
all of a
point. Yeah.
sudden, here it is. Here it is.
Yeah.
I remember Dr. Northrup saying, oh my God, 1,000 years ago, she said that she had a nurse practitioner working with her that used to say, menopause will throw you up against the doors of everything you haven't dealt with in your life.
I heard that. Yeah.
Yes. And so, anyways, to come back to this, so the sympathetic nervous system, of course, is the gas pedal for us. So it's the thing that gets us to move when we're stressed. And it can get modulated on or turned on and then not turned back off. And that safety mechanism is a big part of that. Of course, this is where the vagus nerve comes in, etc. And so, what you're talking about, Karen, is that somebody has figured out by blocking the stellate ganglion, which is part of the sympathetic nervous system as it goes into the body from the brain, essentially modulates it off. Do we like that for things? Because keep in mind, sympathetic nervous system regulates our heartbeat and our digestive function and our circadian rhythms and oh my gosh, the way we interact with our outside environment, so many things. So he must have figured out a way to not affect that part of it so much, but to be able to affect the part. Anyways, I'm real curious.
He talks about it. He
Does
talks
he?
about those
Okay.
things. Yep. Yep.
Giving me a list of things to
I'll
go
send
look
you the
at.
episode, but yeah,
Please.
keep eye listeners, because we'll probably all have this guy on the podcast at some
I
point.
know he's going to do the rounds with the three of us.
I know,
The
right?
menopause besties are coming after you there, Dr. Howe. Maybe we should just do a foursome with him,
Oh God, he'd probably love it. It's probably been on his bucket list since
right?
he was a kid.
That would be fun. Oh
We're
my
talking about
goodness.
a foursome in the golf sense.
Yeah.
I love it. I could talk to you girls forever, but I think we need to wrap it up.
Oh, a
No?
couple more questions.
Okay.
If you guys have time, if you
I
have
do.
time.
Yes.
Yep.
Yeah, yeah.
You have one in mind, or am I going to ask?
Because I don't have that pulled up, the
Okay, I
sheet
got
of
it.
questions. So you go ahead.
I got it because actually you started it when you started talking about this woman who's has really adverse reaction to hormone therapy. So let's talk about the side effects, the negative side effects that can happen with women. Because when we watch social media or listen to our podcasts, it sounds like hormones are the magic bullet and everyone's going to feel fabulous from day one. And it's not like that. And there are some women who feel bad on it. And
Yeah.
so let's talk about some people, some women gain weight, some people feel worse and more anxious or sleep worse. What other things that are women are have feeling bloated when they're
Hot flashes. When I started estrogen, I was put on a really high dose by this doctor, way too high for where I was at. And I had nonstop hot flashes. because I had too much estrogen. Because estrogen regulates the thermostat inside the brain, which then regulates your body's thermostat. And it went the opposite way, where it was like I was hot, so hot and irritated 24/7. It was the worst. And he just said to me, just stay on it. It should get better.
Oh, wow.
And I
Okay.
tried, and then I'm like, no.
Did
And
you
I've
get
tested it out several times where I've increased too much, and that's what happens.
and did you get tender breasts, tender nipples, swollen?
Oh, I had great big breasts. I gained weight. It was a terrible experience. And
Why
so
do I never get the boob stuff? Never. Jesus.
I don't think you want it. You can't even touch them. You don't want to wear a bra. You don't want to wear a shirt.
Okay.
Like,
All
oh, it's
right. All
horrible.
right.
So, yes, I think number one, if you have a bad experience with HRT, don't let that stop you. I can't tell you how many times I've read that online where women
Mhm.
say in the comments, I
Yeah.
tried HRT. It was the worst thing I've ever done. I felt absolutely terrible. We'll never do that again. And I'm
Yeah.
like, oh my God, please don't say that.
Yeah,
You
exactly.
know?
It's so
Exactly.
common to not actually. When I was doing the training with Dr. David Rosensweet in his Institute of Bioidentical Medicine, he said in his experience, and he has 4 decades at least of treating women through menopause, he says about 25% get it spot on, where I just great dose, worked out for her, not too high. He's tested, everything's fabulous. So that means 75% of us are not getting it right the first time, and that's a lot. So it's almost like we should expect just to not get it right, like we have to go several times. And that's what he was doing in his training for these doctors. He was saying, look, you got to tell the patient that they're going to meet with you 2 or 3 times before we actually get it right, because you want to start them on a dosage, then you want to test them and follow up with them. But like you said earlier, with testosterone being too high, you can have acne, you can have hair loss, you can have chin hairs growing. There's all kinds of adverse effects that can happen when you get the hormones, just they're not right, and it takes time to dial them in. And that's actually one thing I really loved about his training, is that he was training doctors, and he gave them this little list of symptoms of estrogen overdose, progesterone overdose or underdose, testosterone overdose and underdose. And then he says, you give this to your clients, to your patients, when they go home with their menopause hormones, then they can actually tweak it themselves based on the chart. And I just thought that was brilliant.
We hand
Yes.
that chart out to all of our patients.
Oh,
Amazing. Can
love
someone
that.
send me
Yeah,
that chart, please? I'd love
I
to see it.
can.
Yes,
Yeah.
thank you.
So
Yes,
good.
That's
absolutely.
It's so
Yeah.
good.
well,
No,
and
I'll
there's
have the
that
chart
whole
also in the link in the show notes in case, because
great
don't
idea.
get that. Yeah.
and there is not one HRT for every woman. And that's, I think, really important. We know that because we all take some form of hormones, but it's speaking up when something feels off, recognizing that maybe what you're experiencing could be a little not enough or too much, etc. I see more not enough than I see too much around here, which is really
Yeah.
interesting. And
Mhm.
that's probably a commentary on the Canadian healthcare system and what doctors are doing. They're trying, but they're just doing really not enough of the hormones. And of course, it depends on a woman's tests. And then doctors say, well, let's not test. So let's just play with it. And so you can see there's some problems there. But what I like to say when people ask me if I think HRT is a good idea, I say, look, I read research every day. I have done that as long as I've been in practice. I love looking at the science. For most of the time I've been coaching women on menopause and the menopause transition, I have said, you can do this without hormones. And then two things happened. We reversed the Women's Health Initiative and things got loud in my body. And I went, fuck this. This is not going to be a matter of paleo diet. I need something stronger than this.
Yeah. And I think that's a
Pardon
rude
my French.
awakening for many women,
Yes.
where they
Yes.
go,
And that's,
oh,
yeah, and
geez,
that's when I
maybe this,
started. Yeah. You're like, maybe
I can't
not.
diet my way out of this.
No, you can't sleep too much out of it. You can't cut back on this or that or whatever. Anyways, but I think what I wanted to say about looking at the research is that it's very clear. that women who take some form of hormones in the perimenopause and starting before the end of your menstrual periods, okay, that women who take hormones have decreased all-cause mortality pretty much across the board, including the big things for women. Number one thing that takes us is heart disease. And then we have brain disease, neurodegeneration, and then we have things like cancers, which, of course, if you're taking HRT, please hear me. If you're taking HRT and you get breast cancer or one of the other reproductive cancers, your chances of having a good outcome are better if you're taking HRT.
Mhm.
So, for those of you that are concerned about the breast cancer connection, that is with the old style of hormones that we used to give women. We know better how to do topical application of estrogen and bioidentical progesterone. Stay the hell away from synthetic progesterone.
I still see
So,
a lot of women taking Premarin or progestins, those
Really?
synthetic progesterone. Yeah, even in Europe. I'm like, why are you doing that? Like, who's prescribing this?
They're still better than no hormones, though.
yeah, yeah, yeah. I
I
was
mean,
going
the
to say,
Women's Health
Zora, yep.
Initiative proves that.
Yeah, yeah,
Yeah.
yeah. It's not great, to be honest. It's not great. But you're right, Karen. The studies have shown even women who took Premarin or Prempro actually still had a better outcome than the women who took no hormones at all.
Yeah, that outcome was 30% less all-cause mortality from Premarin.
The synthetic
They It
progesterone.
was up there
Yeah.
with the cancers too, like up in the high 20s, a 27% reduction in cancers. We know that less you have a drop in colon cancers from estrogen replacement therapy and breast cancer. And it not only reduces your risk of breast cancer, they I've now heard doctors say straight up it is breast protective.
Oof.
So everybody hear that. Estrogen is breast
Breast
protective.
protective.
And if you take estrogen, even Premarin, you're going to have less risk of breast cancer. And if you do go on to develop breast cancer, like Fiona just said, and this is very
Mhm.
clear too, you will have better outcomes and less, like 50% less chance of recurrence.
Yeah. Yeah.
50%
And
chance, less chance of recurrence. That's
Yeah,
big.
that's huge.
huge.
Yeah,
That's
that's
huge.
Dr. Avram Blooming talks about that.
So
He's
good.
a breast
Well,
cancer oncologist.
and 90+% of women that end up experiencing breast cancer survive. But that little bit of information gets left out of the conversation. I think we've all interviewed Dr. Jen Simmons on this on our shows. She is a
Yeah.
great resource for things around breast health, etc. But breast
You,
protective.
I just heard Dr. Louise Newson, and she's a menopause doctor in the UK. And she was doing an interview with Dr. Doug Lucas, who's a bone expert. And it was just a real fast clip. And it's so true what she said if she says, if I were to get osteoporosis and then have a fracture from a fall, my friends would say, "Oh, I'm so sorry about that," but get on with their day. But if she said, "Oh, I've had breast cancer," then it would just be horrifying, and they would be there for you and I'll help you. And it's just as if you were going to die. But in fact, she said, when you look at the stats, if you had a fracture and fall, and we're talking about usually over the age of 65, a lot of people forget that number, but you have a 30% chance of dying within a year.
Yep.
Within a year.
And that's
Yep.
not breast cancer. That's not a
Mm.
breast cancer stat. And everyone's freaking out over the breast cancer thing and not at all about bones and bone health and
Interesting.
osteoporosis and fractures.
Mm-hmm.
It's a little bit twisted.
It
Mm-hmm. Mm-hmm.
is. Yeah. Yeah.
Absolutely. We're panicking about the wrong things. I personally think we can thank the pink marketing campaign, the pink ribbon marketing campaign, for making us absolutely terrified that we're going to end up with dying of breast cancer. And certainly it's true that women do pass from breast cancer, but it's far more likely that if you experience it, you will survive to go on to live your life just fine. And please, if that's you can still take HRT. If you've experienced breast cancer, you just have to find a practitioner who is savvy enough to be okay with signing off on that.
Hmm.
But
Mhm.
they are out there.
Yeah.
Yeah.
So good. Girls, I could talk to you forever, but I think it's time to wrap up. Unless you want one more question. Is there anything else you'd like to talk about before we let ourselves go?
I want to say this is so helpful for me, both of you being able to have this conversation and me leaving with my homework. Thank you very much. So I've got things to look up now, which is beautiful because this is how we learn.
Yeah.
This is how
Yeah.
we're supposed to do it. So thank you for being in session with me today and teaching me just as much as any of my patients do. So I'm so grateful for both of you. Thank you, ladies.
Oh,
Oh, right back
hashtag
at you.
gratitude. Love that. Love
Hashtag
that.
gratitude. Come on, where's the hearts? There we
Hearts.
go. We're making the hearts come out.
Oh, love you girls. Love you girls. And I love the girls who are listening now too. And if you made it to the end of this episode, hearts to you. And we are so grateful that you are in our community. And reach out, let us know if you need any help, if you need any support. We're here for you. And
And how did you guys like that episode? Because we went right off script.
Oh, yeah.
And I really liked that maybe we do this a little bit more often when we have these discussions of let's pull up some of the new research or what we're hearing online and let's talk about it. I think that's a great
I love it.
discussion to be had, you know?
I
I
love
like
it.
that.
Mm,
So, ladies,
again.
if you're listening and you like, go leave us a review on iTunes. Let us know. Only if it's positive. Don't be,
Yeah.
oh, you
Unless you're
guys
talking 5 stars.
suck.
Oh my God, they were shit disturbing. And then somebody said the F word, and I think they're feminists.
oh, love you girls. It's so
Love you
much
too.
fun.
Love you
Thank
too,
you.
Menno Beauty Besties.
Meadow Beauty Besties, we love you. And I will see you girls next time. Take care.